Welcome everyone. So the topic is postpartum hemorrhage. As word indicates, postpartum hemorrhage means bleeding occurs after delivery of the baby. That condition is known as postpartum hemorrhage. Now, postpartum hemorrhage refers to excess blood loss after delivery, and there are three types of postpartum hemorrhage: early postpartum hemorrhage, secondary late postpartum hemorrhage, and massive obstetric hemorrhage. Early postpartum hemorrhage is a condition in which there is excess blood loss greater than 500 milliliter in first 24 hours of delivery. Secondly, late postpartum hemorrhage occurs lasts between 24 to 6 weeks after delivery, and the massive obstetric hemorrhage is the blood loss greater than 2.5 liter, requiring transfusion greater than 5 units of the blood. That is known as massive obstetric hemorrhage. Now, the causes or risk factor are the uterine atony is the most common cause. Uterus become atonic, and that creates postpartum hemorrhage. Macrosmia, fetal macrosmia, those babies who are large, relatively more than 4 kilogram, they may develop postpartum hemorrhage. Obstetric prolonged or labor, oxytocin use, induction of labor can also create this condition. Now, the retained products of conception, placenta previa, placenta accreta, genital tract infection, coagulation disorder, multiple period C-section can also give rise to this condition. And uterine inversion and rupture is also included in postpartum hemorrhage. Now, the signs and symptoms for the postpartum hemorrhage are anxiety, thirst, cold, dizziness, unresponsive. Patient will be unresponsive because of blood loss, and the tachycardia will be there in order to compensation the loss of the blood. So that's why increased blood and increased heartbeat will be there. Reduced urine output, that is a sign of shock. Tachycardia will be there. Hypotension and reduced pulse will be there. So these are the signs of a hemorrhagic shock because of blood loss. Management of the postpartum hemorrhage will be, first of all, the patient has developed shock, so primary survey should be initiated, and it includes airway, breath, circulation, and drug therapy. So ABCDE maintained: stop uterine bleeding by uterine massage, by manual compression, remove any clot in the uterus and vagina. Uterotonic agents should be given like oxytocin, rectal misoprostol, and centrometrine, repeat ergotamine, and carbaprost should be given. So these drugs can also help in postpartum hemorrhage prevention. And in case of the persistent bleeding, look for the genital tract infection, repair that, correct coagulopathy, and DIC call for the senior help. Surgical operations are the uterine artery embolization in order to prevent blood loss, iliac artery ligation, and uterine balloon insertion should be there, and hysterectomy is also indicated for this condition. These are surgical options for the postpartum hemorrhage. And the another condition is uterine rupture or inversion. Uterine rupture occurs during labor that has been reported antenatally. Risk factors are the period, surgical C-section, or congenital abnormalities of the uterus, or use of oxytocin in labor, failure to recognize obstetric labor. In this way, signs and symptoms of the uterine inversion are sudden onset abdominal pain will be there, fetal parts may be easily palpable, rejection of the presenting fetal part, fetal distress, and vaginal bleeding, and a maternal shock can be signs and symptoms. Management of the uterine inversion will be: maternal resuscitation is mandatory, urgent lower segment C-section should be there, vaginal delivery if possible, then vaginal delivery should be done. And there are different stages of uterine invasion. In first stage, inverted fundus extend into the cervix. In second stage, fundus extend through the cervix but not through the vagina, and inverted fundus in third stage extend out of the vagina. And the fourth stage, the uterus is inverted. So in this way, these are the four stages. In first stage, as you can see here, the inverted part is not up to the vagina, and here it is up to the cervix, and here it is the below the vagina, and in fourth there is the complete prolapse or the inversion has been happened. So the risk factor will be full dilation, C cervix, C-section should be there, male presentation, prolonged second stage, abnormal adherence of the placenta, short cord, previous uterine inversion, and strong traction on umbilical cord can trigger this condition. So the management will be: call for help, obstetric hemorrhage protocol should be there to prevent shock, immediate replace, and push up the fundus and cervix should be done. If placenta is still attached, then uterus is left inside to minimize the bleeding, and uterine relaxation can be helpful. Hydrostatic repositioning is also important, and surgical procedures include uh, hysterectomy is the treatment of choice. So in this way, we can manage the uterine inversion. Other are the amniotic fluid embolism. Now this is amniotic fluid embolus. It is a life-threatening condition in which uh, cardiopulmonary collapse occurs, DIC occurs, and risk factors are multiple pregnancies, older maternal age, C-section, instrumental delivery, male fetus, and trauma can be cause of amniotic fluid. Diagnosis will be sudden onset cardiopulmonary arrest, hypotension, respiratory distress, dyspnea, and over DIC onset duration can be there. Now, differential diagnosis are the pulmonary embolism will be there, that amniotic embolism will travel in the lungs and can create problem of the respiration. Anaphylaxis can be there, sepsis and myocardial infarction can happen. Investigations will be ABGs should be maintained, oxygen perfusion should be maintained, and uh, electrolyte should be checked, full blood count, coagulation profile, chest X-ray, and ECG should be checked for management. Management, there is no specific treatment for amniotic embolism, but patient should be admitted in ICU for high flow oxygen should be given and start cardiopulmonary resuscitation in order to relieve the patient. Hypotension, if there is hypotension, give IV crystalloids. Refractory hypotension can be there, so they should be treated by the parental inotropic agents. If coagulopathy is there, then fresh frozen plasma, cryoprecipitate, and platelets will be given. And hemodialysis, plasmapheresis, extramembrane corporeal membrane oxygenation should be given, and intra-aortic balloon pump should be given for the patients. So this was the obstetric complication. These were the obstetric complications which we discussed. In next video we will also discuss other types of the complications.